everyone. It looks like we're getting a ton of people in. So I'll go ahead and get started. My name is Catherine Gray, and I am project manager for MedEd. And I just wanted to say thank you so much for attending care of the patient with mechanical ventilation. This is our second presentation of MedEd's first webinar. So we're very proud and very excited to be able to offer this new service to you. I think most of all, we want to say thank you so much for everything that you're doing in this unprecedented time. And we hope that you're able to take this presentation and apply it to your practice. And also that it will, make you a little bit more comfortable in your day-to-day work environment. So without further ado, I'll go ahead and give it over to our CEO, Steve Allen, who's going to say a few words, give you a little bit of housekeeping, and then we'll turn it over to who you're absolutely here to see, Michael Nanney.
Hi, everyone. Thank you, Catherine. She's been a huge help getting this up and running so quickly. We got this working up in about 5-6 business days, and Michael has been just fantastic to work with. So I really appreciate everybody taking the time out of their busy schedule to watch this. We have almost 600 attendees for this particular webinar. Just some housekeeping things that just want to mention. We had a few questions about contact hours, and we are not providing contact hours for this particular webinar because of the quick turnaround. We just didn't want to, we thought time was way more important to get this information out, so we didn't go through our normal ANCC accreditation process. We are planning on doing more of these type of webinars in the coming weeks and months, and we're hoping to be able to provide those contact hours when we have a little bit more time to get through that process. Also, as far as Q&A, if you mouse down to the bottom of your screen, you'll see a little toolbar that pops up. You'll see a Q&A icon or button. So you can ask questions throughout the presentation, but at the very end, Michael will take time to go through as many questions as possible. So just keep that in mind, that he'll get through his presentation first, and then he'll go through the Q&A after the presentation. Secondly, we will be emailing everybody that is attending a recording of this presentation, as well as the PowerPoints. So you should be getting those in the next couple of days. Just look out for in your email. So just want to introduce Michael Nanney. He's been teaching for MedEd since 2016. He's been a respiratory therapist for over 30 years and a registered nurse for 23 years. He is also involved in educating his fellow nurses at his hospital and facility, and he has a great range of knowledge, and we're really happy to see that he is willing to do one of these webinars, and it went really well on Friday, and we're hoping the same. And Michael, I'll give you the floor and do what you do best, educate.
Thank you, Steve. Thank you, Catherine. So I'm hunkered down here in North Carolina like everybody else. When we're not at work, we're basically staying at home. Like Steve said, I work for a large healthcare system in North Carolina. We have multiple hospitals. I have worked a lot in some different or various intensive care units, transport teams, and so forth. A lot of times in dual role as both the nurse and a respiratory therapist. I have been working in a phase 1 post-anesthesia care unit, but with all this going on, I have cut back my hours in the recovery room because we're just not doing the elective surgeries. And I am really having the pleasure to work with some wonderful nurses in one of our intensive care units for our system that has been designated as a COVID intensive care unit. So they have several patients up there. Just like you guys, I have been scared, I've been anxious. It's been an emotional roller coaster. And of course, we know these patients are on mechanical ventilation. So this is what we're going to talk about several things here. So get comfortable, grab your coffee, grab a glass of wine, grab a scotch. I just want you to relax and let me go over some things. And at the end, I will be doing some Q&As. And so we're going to go ahead and get started let me make sure I've got my screen where I can work. There we go. All this, there's no conflict of interest. I'm not promoting any products or anything. I'm not endorsing any of that. This is just going to be critical care to critical care nurse talk, respiratory therapist. If you're there, thank you, God. Thank you so much that you guys are around. You know we need you. ED nurses, welcome if you're there as well. Okay, got to state the objectives. You know the rules, guys. Okay, this is very important. This is why we do what we do, especially with patients on the ventilators. We got to make sure they oxygenate. We got to make sure they ventilate. We got to make sure that they're comfortable and so forth. So you're asking, what are we doing? This is what we're basically doing. So what is a ventilator? A ventilator really is nothing but a device that is just moving air in and out of the lungs. It's not oxygenating. It's not a respirator. A respirator is something that occurs down at cellular level at the blood. If you think about people getting bypass in the OR during having a cabbage or a valve repair or something like that, and they have to put them on bypass, put them on pump, that's when the perfusionist is helping control the oxygenation and removing the CO2 and so forth. That is respiration that's going on. Basically, it is a device that either assists or takes over and assists the patient when they can no longer do so themselves. So, but for some reason, this device is very intimidating to a lot of new nurses to the ICU or just new nurses in general. The one thing that I want you to start off with is I want you to separate the processes of oxygenation and ventilation. As you can see, oxygenation is nothing but adding oxygen to the body. We know it occurs at the alveolar level. That's where the gas exchange occurs. We know it attaches to hemoglobin, dissolves in plasma, and gets out to the body. We know we have to have that so that we don't become hypoxemic, which is the decreased amount of oxygen in the blood. And then we don't become hypoxic, where we have decreased amount of oxygen in our tissues. And when we don't have that, you guys know what happens. Death occurs because that's what our bodies demand. Now, ventilation is nothing but simply air moving in and out of the lungs. And this is what the ventilator is helping us do. I want you to think the last time that you had a patient that was intubated and you had to manually ventilate them with your bag valve mask. Well, believe it or not, that bag valve mask and you are being the ventilator. You are giving your patient a amount of oxygen, you are giving them a volume of air, and you're giving it at a rate. And if you have an adapter on there, you can add some PEEP to that as well. As we know, ventilation is basically, it's either spontaneous or artificial. Right now, I'm doing a lot of ventilating. But if the artificial is when we intubate and we do the mechanical ventilation, okay? And remember, you have an active and passive phase to your respiratory cycle. You take in a deep breath and you let it out. The active phase is in that deep breath, diaphragm drops, the lungs fill, the pressure changes in your lungs, so air moves in. You exhale, basically just by relaxing, and that's the passive phase. Pressure changes again and the lungs becomes greater than the atmosphere and the air goes out. Now, obviously, we've got to know a lot about arterial blood gases and we have to evaluate those in order to know what we're going to be doing with the ventilators. So here's your quick review. When we look at pH, we're looking at acid-base balance or the status of that acid-base balance of the body. And that norm is 7.35 to 7.45. Then the next thing you look at is your PaCO2. Now, this is your direct measurement of ventilation. This lets me know when I look at PaCO2 is how well the patient's ventilating. I'm not discussing anything here about oxygenation. I'm simply talking about ventilation of air moving in and out of the lungs. If that number is well below 35, then my patient is hyperventilating because they're blowing off CO2. But when that number goes up above 45, then my patient is hypoventilating. That means they're very shallow. They could be very bradypneic and have respiratory rates, let's say, of 6. The PaO2, now we're talking about oxygenation. So if someone comes up and says, how well is your patient breathing? You are going to talk about CO2 or their end tidal, their respiratory rate, what their lungs are sounding like. Then you could say, and they're oxygenating well because this is what their O2 sats are. They've got, they're mentating well, all of those things. So then you're talking about how well your patient is in their respiratory status. And your normal PA2 should be between 80 and about 100 millimeters of mercury. Bicarb, again, is what how we compensate. It's the buffer of what we see the body do when, let's say, we become in respiratory acidosis. The primary issue when we see patients not doing well, especially now with the population we get, these patients are in acute respiratory failure. They have acute respiratory acidosis with hypoxemia. So therefore, that might be an example of what that blood gas looks like. You can see they're very acidotic. Their CO2 is 88, well above 45. So this already tells me that my patient is not ventilating. And because of the CO2 that's retained in the body, CO2 mixed with H2O, water, yields H2CO3, carbonic acid. So therefore, my pH drops. Then we look at the PaO2, he's only 54. All right, obviously someone that needs some O2. And then I look at the buffer system or the bicarb, that has not kicked in yet. I don't see that rising to help me counteract my acidosis. So this is a classic example of respiratory acidosis with severe hypoxemia. So we get oxygen into the body. It comes into the nose and mouth, gets in the oropharynx. It starts going down into the lungs, through the trachea, down to the right main stem, left main stem, all into the bronchial tubes. Okay, so now we're going to get oxygen. Now, when that air is, this atmospheric air is in our trachea and our main stem and all that, air is moving, but it's not doing the process of gas exchange because that occurs in the pneumocytes, those alveolar cells that we have in our lungs, okay? So that's what we have to look at. And the ventilation is how adequately can I get rid of my carbon dioxide so that I don't go into respiratory acidosis. And we can see that example here. Those on the left at the 9 and 10 o'clock aspect of this, I'm going to refer to clocks when I'm looking at, when I'm showing you pictures. We can see the unoxygenated comes in, O2 comes in, binds to the hemoglobin, shoots on out, CO2 comes out. That's what's supposed to happen. That's what we want to see. So what is respiratory failure? It is when the respiratory system fails at either or one of both of its gas exchanges. Either I have a problem with oxygenation or I have a problem with ventilation. And of course, we can see both happening, okay? There are 4 types of respiratory failure. They're classified as respiratory failures type 1, 2, 3, and 4 accordingly. So respiratory failure type 1 is known as hypoxemic respiratory failure. This is where I simply cannot get my patient to oxygenate. So imagine that the patient comes in, I've got them on, they got low sats, I put them on 6-liter cannula, they're still looking crappy, so I up them up to a venti mask, I put them on 50% Venturi mask and get high flow going. They still can't get their sats up above 80, 85. So I put them on a non-rebreather and they're still not responding. This is a patient that is demonstrating respiratory failure to me. In fact, what they're demonstrating to me is refractory hypoxemia. And we got to figure out why can I not get my patient oxygenated. So naturally, the body's going to kick in and go, hey, start breathing faster, work harder, get into a position that you can ventilate. This is not the patient that's going to lay on their back going, I can't breathe. How many times have you seen your patient go, I can't breathe, I can't breathe, I can't breathe? Well, you're talking to me and you're mentating, you're breathing, you're getting some oxygen in. So, so in respiratory failure type 1, think oxygenation is the primary issue here. Now, how can I get that? Alveolar hypoventilation. I can get low levels of oxygen. Let's say I decide to go climb a mountain. I could be a little short of breath because of the altitude changes, or either bad attitude is what I looked like I was trying to say. But anyway, what about like infections, like pneumonia? Think back about your patients that have severe pneumonia, especially your older population. What I see is they're very fatigued, they're exhausted, sometimes they have altered mental status because they have poor oxygenation going on. They just cannot get the O2 in, secondary to the consolidation or the fluid or the infection that's built up in the alveoli. So this patient could be demonstrating respiratory failure type 1. And this is exactly what's happened, because you see there, you've got fluid in there. There is supposed to be a little bit of fluid in our bodies, but we're not supposed to overwhelm them so that the gas exchange cannot occur in these pneumocytes, okay? Now, if you look, when we're talking about ventilation perfusion matching, in other words, what's happening is that my cardiopulmonary system, now remember, cardiopulmonary, cardiac and lungs, everything's working good. I got a good blood pressure. I can get the O2 in. I got good blood flow. Then my CO2 comes out. Where it becomes ventilation perfusion mismatching is things that either block about with the oxygen, such as, think as a pulmonary embolus. Think about, let's say I have severe emphysema, or pneumothorax can do the same thing. Or I have bad perfusion, my blood pressure is shot. I'm sitting there with a map in the 40s and 50s. Then I can develop ventilation perfusion mismatching. We want our patients to be ventilation perfusion matching. So this is why we're doing a lot of things to make sure our mean arterial pressures are staying around 60 to 65 in our critical care units, especially with the type of patients that we are now caring for. So how do we get those ventilation perfusion mismatchings? Pneumonia, pulmonary edema. Those are some problems there in the respiratory system. ARDS, classic, is one that we're going to get ventilation perfusion mismatching problem there. Now, so you look at the ARDS here, and I'm going to talk about ARDS at the end and sort of related to the type of patients we're now seeing that we're challenging to care for. But you can see on the left, and you look at this pneumocyte or this alveolar cell, and you can see that I have, wonderful aeration in there. It's nice and full. I've got a nice thin area or spacing between my alveolar and capillary membrane. Now look to the right, then I've got all this other stuff going on. I've got fluid in there, and now I've got a widened out alveolar capillary membrane. I've got a lot of fluid in that interstitial area. You can see where the gas exchange issue is going to be. So this patient now has ventilation perfusion mismatching. So respiratory failure type 2. Type 1 is oxygenation. Type 2 is ventilation. Okay, this is where they have hypoxemia with hypercapnia. What did I just say? I just said low O2 with an elevated PaCO2. In other words, my patient is not ventilating. Let's take one of the simplest cases that we see when a patient goes into acute respiratory failure type 2. You're doing moderate sedation, or you go in, you give your patient their PCA pump, and they're hitting that button like crazy. Next thing you know, they got a respirations of 6, their end title's elevated. Your patient just went to respiratory failure type 2, and you're like, all right, too much partying here. We got to take that away. It's not a party drug here. Okay, so what you see, now here are the criteria. Your CO2 has to be above 50. Okay, so we should know the PaCO2 is 35 to 45, but they get above 50. So when that happens, we know again about the CO2 in the water, the pH is going to drop, we're going to see acidosis. Remember, with CO2, with the respiratory issues, with CO2 and pH, they're indirectly proportional. That means as one goes up, the other one is pretty much going to be down. And also they have hypoxemia, so their PaO2 is less than 60. And normally that PaO2, or partial pressure, or alveolar oxygenation is what that stands for, means that that oxygen level should really be between about 80 and 100. So what we have here is that we have ABGs that are reflecting acidosis with hypoxemia, and this is respiratory failure type 2. Again, causes, opioids will do it, a lot of benzodiazepines. I even have up there morbid obesity. Patients that are very huge don't ventilate. Think about the proportion of the abdomen and the chest wall. When these patients are laying down, all that abdominal area is pressing up on the thoracic cavity, is pressing up on their lungs. So now I've got lungs up here instead of down where they should be, where the diaphragm should be. So now we can understand why these patients are like huffing and puffing and just doing small tidal volumes. They're just breathing like that. They almost look like they could be panting. Neuromuscular diseases such as Guillain-Barré syndrome, pectus excavatum. This is where you see, especially in newborns, basically males, is where the chest cavity is sort of like caved in. It causes a restrictive lung disease. So therefore they can't get the air in. This can lead all that into respiratory failure type 2. So what about using the end-tidal CO2 and all that? So this would help me determine if my patient is ventilating, because like I said, the CO2 is the direct measurement of ventilation. So as you can see on the top waveform, that is the normal waveform that we should see. What we're seeing now is that A to B, the patient is now starting to exhale. They are exhaling completely at C, and at the end of expiration, right before they take the breath to breathe in again or to inspire or to go through the active phase of the respiratory cycle, that is your end-tidal CO2. And they're keeping it simple. Think of arterial CO2 at 35 to 45. Your end-tidal is using the same values. That's how good our devices are. So now look at the one at the bottom, the waveform, compared to the top. And simply what you see now is a patient that is probably slowing down their respirations, and now they're not taking good deep breaths. So now we see the CO2 rising. So what I see here is that this is a patient that I need to start stimulating or trying to get them awake to take good deep breaths. And if that's not the case, they're basically going into respiratory failure type 2. This is a patient that is not ventilating well. This is a great little screen that you get. I got it off of Google. I like to use Google. It's got everything on there. And this just tells you that respiratory failure type 1 deals with oxygenation. We call it hypoxemic respiratory failure. And type 2 of acute respiratory failure is known as hypercarbia respiratory failure. And you can see your criteria that are there. So the patient is going to, in respiratory failure type 2, which is the one that really scares me, is the patient that has got CO2s above the 50s. And now look at that pH. It's less than 7.30. I'm going to go ahead and tell you now, that's going to be an indication to most likely get this patient on BiPAP or either go ahead and intubate this patient. And you can see your basic causes. So this is a nice little screen to have. So how does the body respond? You know, our body's very good. You know, if you start running, your heart rate's not going to stay 60 and your respiratory rate's not going to stay at 12 to 14. You do compensate. Your body starts, you know, heart rate goes up, you become tachypnic, you become a little dyspneic. So your chemoreceptors are very good at helping us with patients that are helping your patient that goes into respiratory failure or starting to head into respiratory failure type 2. Located in the carotid, the brain, the aortic arch, they're the receptor cells that sense changes in carbon dioxide. And as they're very sensitive more to the pH, and as that pH drops, this chemoreceptors are back here screaming, take a deep breath, breathe faster, increase the heart rate, let's get rid of the CO2 and let's get the O2 in, is basically what it's telling the body to do. So, so you can see now how well it works, because even as much as 2 to 3 liters of increase is going to happen for almost each millimeter mercury rise in CO2. So if my CO2 starts getting up above 45, 46, I am going to start breathing a whole lot faster. My minute ventilation is definitely going to change. I told you there were 4 types. Really not going to get into type 3 and type 4. That's another discussion. But in respiratory failure type 3, that's simply the patient that has had like general anesthesia or deals with surgery. Think about your patient's got a major incision from an exploratory lap or has had thoracic surgery. They're not going to want to ventilate as well. So that would be the cause of that, or the general anesthetic would be the catalyst for that. Respiratory failure type 4, yeah, shock. This would be like your septic patient. So you think about your septic patients who are not starting to ventilate very well and don't have very good blood pressures because of their cardiac status or their hemodynamic status is in the toilet here. They're going to be experiencing respiratory failures type 2 and type 4. I did want to mention, because the last time we had somebody that says, well, talk to me about CPAP and BiPAP. CPAP is basically one setting. We see this is used for our patients with sleep apnea. This is oxygenation. It applies pressure, continuous positive airway pressure to help keep the oropharynx open so that we don't get all that snoring and that relaxation, which occludes the airway. And patients that have severe obstructive sleep apnea, they have high apneustic indexes. In other words, they watch their sats drop, and they're measured about how many times they desaturate per minute. And that sort of helps them determine about obstructive sleep apnea. Now, BiPAP is very good. This is actually known as non-invasive positive pressure ventilation. And this is going to help me more with ventilation versus oxygenation. So the patient that comes in, this is really good with somebody that's in initial phases of a pulmonary edema. We could put them on this so that we can keep from intubating that client. And we're going to help them get over we're going to assist them with the active phase of the respiratory cycle is basically what we're going to be doing with that patient. But you have to understand, for them to be on BiPAP, that patient must have spontaneous breaths. That means that patient needs to be breathing on their own. They've got to tolerate that device, because think of that device with that face on there. If you can't breathe, you really don't want anything covering your face. And can the patient follow commands? So this is some of the criteria for BiPAP. So it works very well. We've used it before we've intubated somebody, and then we've even used it after someone has been intubated. We've got them extubated, and we thought, okay, they might start teetering, or we're going to have to re-intubate, but we put them on BiPAP and help them and prevent re-intubation. We've used this sometimes in the recovery room for patients that are in respiratory failure type 3, which deals with the perioperative respiratory failure. So what are the goals of mechanical ventilation? Why are we going to put the patient on there? Well, one, we're going to intubate them to protect their airway. Some people may lose that gag reflex. Some people may become very unresponsive and not have their airway protection. We're going to facilitate oxygenation and ventilation. In other words, when someone's intubated, I'm going to oxygenate them better. I can set that ventilator to make them breathe a whole lot better. Because, once you have that closed system or you've got a nice patent airway, we know fluids and gases follow the path of least resistance. So we're going to provide adequate oxygenation. We're going to improve our ventilation. We could correct that respiratory acidosis with the severe hypoxemia. The patient who is very tachypnic, what if someone is breathing at 38, 40, 42, even to 50 breaths per minute? We know that we cannot do that. That is not what humans do. I tell everybody, we own a bunch of chihuahuas at my house, and they pant. They can breathe like that. I don't breathe like that. The other thing, too, is that we intubate somebody to protect them from further insults. So what does that mean? If I've got a patient that's going into ARDS, if I don't treat them now, or let's say they have pneumonia, they can become worse. But if I can get them sedated, intubated, and mechanically ventilated, then I can protect them and prevent from further injury to the lungs, because I can start helping the patient relax. We can ventilate for them, and we sort of can let the lungs just sit back and go, okay, I'm going to rest until I heal, until I can take back over again. Now, this here are sort of the numbers of the indication. This is what respiratory therapists look at. This is what sometimes pulmonologists look at for reasons to start considering intubation mechanical ventilation. Again, very much tachypnea. pH less than 7.25. Somebody that's acidotic, we need to get that corrected. The body just does not work well when you are severely acidosis or acidotic. The body likes us to keep her at 7.4. Okay, she is not one that is very forgiving. Altered level of consciousness, think about the patient that is very unresponsive. When I worry about someone that has very poor Glasgow Coma scale, that has very much altered LOC. I am worried about their airway. This is not the time that you need your patient to vomit, okay, because they can't protect their airway. They vomit, they get aspiration into the lungs. That's a direct injury to the lungs, and therefore that all that very acidic stuff that's coming from the gastric contents causes the patient to start getting into, it leads them into ARDS, and you know we all don't like that. The patient who has periods of apnea, okay, they're breathing for some reason, what's going on there? The very hemodynamically unstable client. Patients that are very bradypneic, these are again going to be indications. Spontaneous tidal volume less than 5 mils per kilogram of ideal body weight. Okay, so as an RT, they would look at this and they would say the patient is not ventilating. So instead of sitting there, and you know what a patient looks like when they're breathing very well. You know, you've lifted up their gown, you listen to the breath sounds, you see rise and fall of the chest, you see the patient very comfortable. But if you lift that gown up and listen to breath sounds and you don't hardly see any chest movement and the patient is sort of obtunded, their tidal volume, which normally probably be about, let's say 300 or 400, now it's only 100. That's telling you the patient's not ventilating. Your patient's in respiratory failure type 2. So when we don't ventilate, CO2 rises. CO2 rises, it leads to CO2 narcosis. That in turn leads you to become even more tired or sleepy or have more altered level of consciousness. So when you don't do that, then that CO2 is going to rise even more, and then that pH is going to drop, leading to that pH of less than 7.25. The other one is called the accessory muscle use, or the NIF. What is the negative inspiratory force? They have a way of checking that. They basically, let's say a patient just cannot take in the deep breath. We normally check this as part of weaning parameters to see if the patient has the strength to breathe without the ventilator. And then, of course, acute is the term I should have preceding on this statement, but acute respiratory failure type 1 and or type 2 would be another major indication to intubate your client. So you look at the ventilator and you walk up and you look at this, and of course I did it before I went into RT school, and when I was just a little, what they call an O2 tank jockey, I ran around and filled up all the, or went around and supplied the RT department. But as a new nurse or someone new to the ICU that sees a ventilator, they walk up to this and they're like, Christmas on a cracker here. What is going on? So when we finish talking, I could go back to the screen and you're going to know exactly what the settings are for this patient. So ventilator settings that you as a nurse need to know about. Okay, this is what you should be able to give off in report. We're going to talk about the modes of ventilation. We'll talk about tidal volume, respiratory rate, what their FiO2 or oxygen level is set out on the ventilator, what is their PEEP level set on the ventilator, and do we have pressure support is another one that you may be reporting off onto your oncoming nurse. Okay, so the mode of ventilation. How am I going to deliver the breath to the patient? What am I doing in order to facilitate ventilation, which will eventually help with oxygenation? Okay, this is based a lot of times on the condition of the patient, what is going on with them. It could be determined by protocols of your hospital system, of what you're going to do. It's you know, one thing you think about when a patient that you're going to sedate, intubate, and mechanically ventilate is, why are we doing this? And understanding that will determine a lot of times what kind of mode of ventilation that we're going to be using with this patient. A lot of them are volume, deal with the volume, about how much volume I'm going to give the patient in their tidal volume, how much air I'm going to deliver to them, or how much pressure is going to be involved if I'm going to do a pressure regulated type of ventilation. Now, I want to start with this because this is easy to explain. This is one of the older modes of ventilation. I remember when this came out. So it helps you sort of understand everything else about what's going on with the ventilator. So when I look at a mode, when we used to put patients on what we call synchronized intermittent mechanical ventilation, what it was doing was that it's basically that the ventilator, and if I go to the next slide, I can explain better. So look at the third line down in at time and volume. So what is, there's a certain volume that is set on ventilator. Let's say this guy is set to give him 500 mil volume. So in SIMV, what would happen is that at the first waveform, the ventilator delivers that breath of volume. The ventilator is going to give him 500 mils of tidal volume. And then what happens is that it's starting now to start to become time again for the machine to say, okay, Fred, I'm going to give you another breath. But Fred decides that he wants to take a few breaths on his own. The ventilator would back off, or in this mode, the ventilator would back off and say, Fred, go ahead and take some breaths. So Fred goes ahead, does a couple little breaths, and then he breaks out, you know, he sort of can't do it. And then the machine comes along behind and says, all right, Fred, here's another tidal volume of 500. So it's very good when we need to assist a patient or we're trying to wean the patient off the ventilator. So this would be a good volume one to use with somebody that I just need to maintain them until they get the strength up or until they can do their ventilation again. They could start breathing on their own. Now, in our area here in North Carolina, what I'm seeing in our critical care units is this mode of ventilation. The therapists tell me this is the holy grail. It's called pressure regulated volume control. We just report it off as PRVC. Our therapists have a lot of autonomy. They just go ahead and put the patient into this mode. It helps use pressure along to give the patient a volume. The therapist sort of set where they would like the patient to get as far as volume, how much volume of air we're going to get, but it's also based with pressure being delivered. And what it does is it works based on the compliance of the lungs. So someone who's very sick, who has poor compliance, may require a little bit more pressure. Those that are very, that have very good compliance could require less pressure. Those that are very non-compliant lungs would require a little bit more pressure. The beautiful thing about it, it decreases lung injury, it decreases that barotrauma, maybe even some volume trauma that is one of the side effects, one or two of the side effects from being on mechanical ventilation. So look at the top line and what you see, and I want you to compare it with the second waveform. The first waveform deals with pressures. So, and the second one deals with the volume. So the therapist wants the patient to be at a certain volume. So you could see the pressure will adjust to get that patient to that volume. So instead of every breath, let's say in SIMV, being, let's say 500 mil volume for every breath, that volume is going to vary a little bit, but because based on how much pressure is needed to deliver, used to deliver that volume of air. So we see tidal volume listed either as TV or capital V lowercase t. And again, it's the amount of air being delivered. So now we're talking about the tidal volume. So it basically, after you learn all this, you would just say, I would come up and say, oh, I see Fred's on the ventilator. What are his settings? You're going to say, Michael, he's at PRVC 525, rate of 12. His FiO2 is 0.6, and he's at 8 of PEEP. And I'm going to know exactly what you're talking about, and you're going to be able to do the same thing. Tidal volume normally is adjusted or is set up based on ideal body weight of about 4 mils to 8 mils per kilogram. Now, what we're seeing now is that we're looking at height to help determine what the tidal volume would be at 4 mils, 6 mils, or 8 mils. And it went back, it went to that, and it's like one of the respiratory therapists told me, weight changes, but height stays very consistent with a patient. So they use the height in there as part of the calculation, and it's already built into our EMR system, our electronic medical record system, that the therapist goes into, and they know, and they've already got it calculated out. Like what we're seeing with our patients that we're caring for now, they've got it written up in the room what the tidal volume should be for 4 mils per kilogram, 6, 8 respectively. So the tidal volume is then is set, it's based on patient's carbon dioxide level. What is the disease process? What is the issue? Why did we intubate? And so we look at all of those things to determine a lot of times what the tidal volume or the amount of air is that's going into the lungs. And here's that graph on the left that talks about height, inches, and you can see where it's all calculated out. And this helps. So you could see that on somebody that is like I'm 5'8", so if they wanted to put me at 6 mils per kilogram, they would probably most likely set my tidal volume at 410 mils to be delivered to me. So it won't be based on my weight of 175, 177, okay? Now, respiratory rate or frequency is how many breaths per minute that ventilator is going to deliver to the patient. So, all right, so take, for example, if you got somebody that has got high CO2s, let's say their CO2 is 60, and I got to get that down, then wouldn't I want my patient to breathe more? So, yes, I want to ventilate them at a higher rate. So most likely what you would see is, let's say we would see a respiratory rate set at like 30 on the ventilator because we need to correct it. We need to get the patient to blow off the CO2. So you can see where those changes, why the changes would come in. So the setting for respiratory rate or frequency is based off of what the patient's work of breathing is and or what their PaCO2 results are from their arterial blood gas. It also could be adjusted by their end-tidal CO2. And we're seeing a lot of end-tidal CO2 and continuous pulse ox monitor on patients with ventilators because in that way we don't have to do so many arterial blood gases, and it may also prevent us from having to insert an arterial line. Now, oxygen setting is fraction inspired oxygen. It's known as FiO2. It's written in percentage form. So if I say, what is their FiO2? You could say they're at 0.4, meaning they're at 40%. Or you could just say 40% is what their O2 is set out on the ventilator. Again, that is going to be based on patients' needs. It will also be based on patients' history because we know patients that are chronic lungers do not need as much oxygen, like that COPD patient. We give them more oxygen, they're going to sort of have stop breathing because they work off of the hypoxic drive. Their body responds to the levels of O2 in their body, not the levels of CO2 as we normally would. So we would titrate that FiO2 based on the ABG or the pulse ox. And you have seen this working in critical care, working in DE. You look up there and you're like, oh, my patient's 85%. So you increase their oxygen level, even by if it's a mask or if they're on a ventilator, you have the therapist or your respiratory therapist will do it because you also have to look at what does the physician want the patient to be at. Right now, we're seeing orders to keep our patients that are COVID positive. We're looking at keeping our pulse ox between 88 and 90%. So I don't want somebody 98%. So I'm not going to have them on really high PaO2 unless I need to achieve that, to get them in that range of 88 to 90%. PEEP is great. PEEP helps me oxygenate my patient, positive end expiratory pressure. It recruits the alveoli and it helps keep it open so that the alveoli is next to the capillary bed. Here's my alveoli, here's my capillary bed. I want this. This facilitates gas exchange, basically oxygenation. Look at the patients you're dealing with now, okay, especially ARDS patients. You get a lot of fluid in the interstitial area, you get this crappy little alveoli. I now have this type of situation. I'm going to have problems oxygenating that client, okay? So PEEP is very good. You have natural PEEP that is in your body now that is working off of your epiglottis develops your PEEP. And it helps keep the alveoli open. It's about 2.5 to 4 centimeters of water pressure. So now you can understand why we put patients on PEEP when they become intubated, because now I have bypassed with that ET tube down. Here's my epiglottis is up. I can't do the natural physiological PEEP that I have in my body. So the therapist will put PEEP on there, and they usually put them at least 5 centimeters of water pressure. Now, So that helps with the oxygenation. Of course, that is going to be increased based on the needs because it's going to help with O2. Because your patient's now at 100% on the ventilator, but they still have crappy PaO2 on gases or poor pulse oximeter when you're looking at your monitor, then let's add in that PEEP. Now, PEEP is very good, but PEEP is also very bad. It causes a lot of pressure into the lungs. It also increases intrathoracic pressure. So therefore, you have a decrease in venous return. When you have decrease in venous return, you're going to have a decrease in cardiac output. So now your blood pressure is starting to look crappy. Okay, your MAPs are no longer 60 because they're on high levels of PEEP. So we have to do something about that. What happens after about 48, 72, 96 hours? You start seeing your PP start being decreased because now I'm not perfusing my renal system. So now my patient is going to go into pre-renal acute kidney injury. And where do you see that? You saw the creatinine level go up. So now we got to fix that too. But PEEP is good. We say it's better, even though it's got all those little side effects. Okay, so it helps recruit the alveoli, functional reserve capacity. What that means is the classic example when you say someone has good functional reserve capacity is like you got a patient that's been laying in your bed in the ICU and they're on 4 to 6 liter nasal cannula. Their oxygen level is really good. You get them up, you can move them to a chair, they get up and stand in the room, and that level stays up. Where we say somebody's got poor FRC or poor functional reserve capacity is you get them up out of the bed, you move them, and their sats drop out. And you're like, they got poor FRC because their alveoli are just not working as well. So by increasing PEEP, I can decrease my FiO2 because what happens when patients are on high levels of oxygen for a long period of time? Oxygen toxicity. And you know the side effects of oxygen toxicity, okay? Real quick, sometimes patients are on pressure support ventilation. So imagine having the endotracheal tube in you. Imagine that you've got all of that long ventilator circuit and you're trying to breathe. The best example I can give to you is you go outside and try breathing through your garden hose. You're going to work really hard. So let's say something is on the other end that when you take in a breath, when you get into the active phase of inspiration, then what you see is there is this pressure that comes through to help you take that deep breath. I'm standing behind you, you go to take a step, I give you a push. The patient, I give you a push, it helps you take that step. I'm helping you decrease your work of breathing. It is great to overcome the tubing resistance. It is great for weaning. It helps the patient not have to work so hard. Let the therapist set that because they usually set that based on some tidal volumes that they want to see the patient do. So they may make adjustments to that. But do know that pressure support ventilation is a nice option. I like to compare it to having a heated steering wheel in my car versus not having it. It's nice to have. Okay, so we're going to be making, let's say or doing setting changes and everything. Those changes are going to be done on several factors. One, what does your blood gases look like? Is your patient still acidotic? Okay, let's make some changes. What is their chest x-ray? Do we see it improve or is it getting more crappier? What does the patient look like? What is the needs of the patient? Do we have to now, if I've got someone on low settings, let's say low respiratory rate because I was trying to wean them, but now I've decided to put them on a propofol drip. I've got them on a Nimbex drip, okay, or Vecuronium drip. Then I'm going to need to make some ventilator changes because if I have someone paralyzed, I cannot set their respiratory rate at 4 breaths per minute. Also, hemodynamic status. If they're really crappy, we may not be able to put them on large levels of PEEP. We may have to cut that back a little bit just simply because of the effects that it does cause on our hemodynamic system. Okay, so changes that we would do that would help us make changes in their ventilation. You would see the therapist or the physician order that we may need to adjust the respiratory rate. How fast were you breathing them, or we need to slow it down a little bit because now I've made my patient be hyperventilating. They may have to make changes to the tidal volume, but respiratory rate is most likely going to be the first thing you're going to see. We may need to change the mode of ventilation. There are several modes of ventilation that the patient may be getting to. We may have to put them in what we call CMV. control mode ventilation, meaning we actually end up paralyzing the patient and we take total control of that patient's ventilation and their volumes. They do not do anything because they're now paralyzed. They might have to be on high frequency oscillating ventilation that sometimes is used with patients that are in ARDS. So changes that ventilate, look at the CO2. So if your CO2 is high, then you would expect your physician or your respiratory therapist to go in and make changes to the respiratory rate to help blow off that CO2. In changes that deal with oxygenation, let's say you're at 100%, you get back your blood gas, and the patient's got a 500 and some PaO2. Well, we don't need that. They only need to be between 80 and 100. But therapists say, cut that patient down to like 75%, cut them down to 80, then let's cut them down to 60. We don't need for them to have a PaO2 of 500 and some. They may need to adjust the PEEP. Again, PEEP is that ancillary support to help us oxygenate the patient. Inspiratory time deals more, the respiratory therapist is going to deal with that. They have certain settings that they do with patients, but it's the time it takes for the inspiration. They may need them to be longer so that they hold that breath in more. That's going to help with oxygenation, but you don't need to mess with that. You may be asked to adjust the oxygen level if you're in isolation, like we do a lot of times, like the therapist will knock on the glass, say, hey, cut that PEEP down. We'll have that conversation and I can make that change on the ventilator. As far as alarms, it's a machine and that thing goes off. You guys know it goes off, and the first thing you do is you roll your eyes and you're just like, I just took a bite of food. So look and see what kind of alarm is it? Low pressure alarm. That means that there is a disconnect in the system. That means it could be loose tubing. There's a leak somewhere in there. It could be the ET tube. We got low pressure alarm, like looking at all the circuits, we're thinking what's going on. The patient has bit their ET tube and has a hole in it, so I no longer have a closed system. High pressure alarm, this is when the patient's coughing. This is when the patient's biting the tube. This secretions. They have bronchospasm. They become out of sync with the ventilator. They become dysynchronous. They're agitated and they're fighting and bucking. You can have that. My thing with alarms as a nurse, one, find the silence button, cut that off so I can think. Two, manually ventilate my patient. Unless I just look up and I say, oh, you're disconnected from the ventilator, Fred, let me connect you back. If I can't find it, I manually ventilate my patient. And I just ask somebody to please call the respiratory therapist. Let them come along. That's their machine. They know the ins and outs of it. I don't want to deal with it. Think, again, use from the trauma nurse care core course, think DOPE. Do I have a disconnect? Do I have an obstruction? Did my patient develop a pneumothorax? That will cause high pressure alarms. Or is it that crazy equipment, that ventilator? If you can't find it within a few seconds, manually ventilate your patient. If they're a little bit awake, reassure them. Just try to do about the same rate. And you know how to ventilate a patient. We're not going to get into that part of this lecture, and let the respiratory therapist come do that. As far as ET tubes, I just want you to know patients are very good when they're awake of how to move that tube. They will grab tubing and pull on it and get a hold of the tube. They have a way of using their tongue. Sometimes the tube is above the vocal cords or right at the vocal cords so you can hear a leak. Sometimes patients get right mainstem intubation. Just simply, it's easy to do just simply because the right mainstem is more straight and the left mainstem branches off just simply due to the anatomy of the cardiothoracic system and where the heart sits. Cuff leak, your respiratory therapists are keeping up with that cuff, but if it's leaking, then you don't have that closed system. We know gas takes the path of least resistance. Some patients just don't tolerate that tube. So it's time to screen, and I screen, you screen for a benzodiazepine. So let's get some patients some sedation on board. So what about assessment of these patients? Naturally vital signs. Your patient's in the ICU. You're going to be watching vital signs sometimes as much as every 10 to 15 minutes based on your patient. What are your breath sounds? Do you truly listen to your breath sounds like you're supposed to? Do you do a 4-point check? ABCs, ABCs, bass, bass, and document that. You need to take the time to listen to that. Look at the last ABG if you haven't. If not, watch your end-tidal CO2 and your pulse oxes. Where do you stand on that? Are they in acceptable ranges for that patient at that point of time of his disease process? What kind of secretions do you see? Also, what are your ventilator settings? What is your mode of ventilation? What is your tidal volume? What is the frequency? What is the FiO2? And what is the PEEP? Do they make sense? Are they helping you obtain what your goals of end tidal or pulse ox are, your goals of your arterial blood gas? Also, it's the cardiopulmonary system. What's your cardiac assessment? Do you have a lot of ectopy? Because if you have a patient that's demonstrating a lot of PVCs, it also could be respiratory related. Frequent PVCs is one of the latter signs of severe hypoxemia. ET tube evaluation assessment. So what do I mean by that? Well, where is it? Is the patient orally intubated? Are they nasally intubated? Or do they have a trach? If they're orally intubated, nasally intubated, what is the size of the tube? That is written on there. It's a 7, 7.5, 8. What size tube do you have? And then where is it marked at? And we use the teeth instead of the lips. So in report, I would say Fred is orally intubated with an 8.0 tube at 24 centimeter mark at his teeth. That lets the next nurse know, because every time you move your patient, you turn them or you take them to CT or get them up to a chair. Yes, sometimes we've got intubated patients who get up to a chair. You have to assess that endotracheal tube. Other things to assess as a nurse is, what is the chest x-ray reading? Okay, get in the habit, if they come around, do morning chest x-rays, get in the habit of pulling them up and look at them. They're fascinating to look at, especially now with the type of patients that are our primary patients in the ICU. What's your patient comfort? What's your RAS score? What's your Glasgow Coma score? What is your CPAT score, your critical care pain observation tool? What is your patient doing? Don't forget about your mouth care and the thing. You'll see the respiratory therapist move that tube from side to side because we don't want breakdown. Check that from the tube holder and make sure you're doing your VAT prevention, your ventilator-associated pneumonia. We know that's a healthcare acquired infection, and HCAPS keeps up with that. So, yep, you still got to do those little things because there's a bean counter back there that's watching that. This is what I like to do. I like to write down A, B, C, and D to start off my assessment. I just put it on a piece of paper. What airway do I have in? Where's the markings? All that is previously mentioned. Breathing, what are their ventilator settings? What's their end titles and stuff when I look at CO2? Let me look at all my numbers. There's urinary output, capillary refill, skin, anything that tells you about the cardiac system. S1, S2 there. What kind of rhythm do I have? All that stuff like that. Am I in sinus rhythm, sinus brady? Do I have ectopy? What's going on? And D, that neurological status, meaning deficit. What's my RAS score? Glasgow Coma. Do we use AFU? Can the patient give me thumbs up if I say, how you doing, Fred? And he gives me a thumbs up. So those are some good things that you want to know. As far as sedation, we know that we use a lot of different sedation. Why are we doing it? One of the biggest reasons is to decrease the level of the stress hormones, okay? And also to let the patient tolerate that ET tube and tolerate what type of ventilator mode that they're in. There's a wonderful article out there that they asked a bunch of patients to describe in one term what it was like to be on a ventilator. Drowning, anxious, death is what they thought of. They had fear. They felt, they just had so many, and it was just amazing to see that list. So this is where your nursing truly comes in and reassuring your patient. But the other thing is making sure they're sedated, because if you go back to that first statement I had, that very first slide, is one is we need to ensure our patients have good comfort while they're being mechanically ventilated. Effects of sedation and analgesia, especially POR and all that, if we don't sedate them correctly or properly, and we know that medications, all it needs to be customized for every patient. Not every patient can do 50 mics of fentanyl and 2 of Versed every hour. Some patients don't, that's not enough. Some of them, that's way too much. So respiratory wise, you will see tachypnea. You'll see them become async with the ventilator. Because they're working so hard, that's going to cause them to need more oxygen. Cardiac, they can become very tachycardic, or they can become very bradycardic. Hypertensive, patients actually could have myocardial ischemia. You could start seeing some ST elevation. We've seen patients on ventilators be so stressed out of what's going on, the patient actually experiences a STEMI. Gastrointestinal, This is why we like patients a lot of times to be NPO, because we can delay gastric emptying. Grimacing, sweating, anxious, agitation if we don't properly. And the other thing too is sleep deprivation and anger and stuff like that. Patients that don't get enough rest are not going to be able to eventually have the strength and not be able to basically become weaned and extubated. So I like where a lot of ICUs, when I travel around, I hear they have these nice little quiet times. Let's say from 1 a.m. to 4 a.m., you're supposed to be as quiet as you can and let the patient sleep. In your pain assessments, CPOT, use RAS score, watch your vital signs. BIS monitoring a lot of times is being used with patients. Everybody knows the RAS score. I just threw it up here just to familiarize you. I love this because the orders that we get a lot of times with patients on ventilators is to, let's say, part of it would be the goal is to keep the patient at -1 to -2. Well, that's really good because everybody understands the RAS score. They know that I need the patient to be enough that he could open his eyes but easily fall back to sleep. Critical care pain observation tool, yes. You got to assess your pain level. You know, pain is something that we do. We used to, us experienced or older nurses used to hear pain is the 5th vital sign. So we've got to address our pain status with our patients. BIS monitoring, if you're using that, remember 0 is you got no brain activity, 100. If they're up there, there's no unit of measurement with the bispectral index that your patient is fully awake. Your goal for moderate sedation is to get the patient to 70, 80. If you start getting down to 40 and 50, that is considered general anesthesia. That is not where we want the patient to go because there's a lot of hemodynamic effect that occurs with those patients. So your goal is to be somewhere between 70 and 80 for sedation wise, and that's sort of evidence-based practice there. We are doing a lot of, you can see some patients get a lot of paralytics. Nimbex is one that's being used because one reason why it's so nice is I don't have to worry about the renal system or the hepatic system as much. Vecuronium is another one that's sometimes used, but you do have to be concerned with patients there that do have renal or hepatic issues. You can see you put it at the ulnar area, and your orders may be to keep the patient to have, let's say, 2 twitches or 3 twitches, something like that. So if the patient is twitching, then you're usually probably more down to about 50% blockage. So, because you don't want to ever get 0 twitches. That means that it's all affecting the blocking of the acetylcholine and helping that contraction of that muscle and so forth. So you would see those twitches that would be occurring. Now, weaning and extubation. So we're getting our patients well, they're ready to be weaned. All right, the first thing I want you to remember that weaning is moving the patient from be totally from mechanical ventilation to where they're able to be unassisted. Now, weaning and extubation are 2 separate processes. Okay, we got to wean the patient from the ventilator first before we extubate them. You need to be having discussions when someone comes around, let's go ahead, we want to extubate Fred today. It was like, okay, what are we going to do about start weaning? And where's RT? I like to have that conversation with, let's say in the PACU, I want the RT there, I want my anesthesiologist there and me there so we can discuss about how we're going to do this. And do we all agree that the patient is able to be weaned from the ventilator and most likely to be extubated? Well, the same thing needs to happen in the critical care unit. So it takes that team approach. The one things that you have to look at, the criteria is are the ventilator settings appropriate for somebody to wean? If you have them on total control mode and they're at 100% and 12 of PEEP with a respiratory rate of like 30, that is not a patient we're going to be weaning yet. We got to get them on down. We're not going to wean them off the ventilator and get them extubated. So things we need to look at, is the lung issue stable or has it resolved? So we need to look at all that. That would be looking at the chest x-ray, breath sounds, secretions, all that stuff. Is the patient stable hemodynamically? Also, is the patient trying to do some breaths on their own? And this is something where the therapist could look at, and you will be able to look at, because you will look at the spontaneous tidal volume on there and you can see what the patient is doing on their own. Do they have good neuromuscular function? So meaning, one, can the patient raise their head up off their bed and do what we call a sustained head lift for at least 5 seconds? That lets us know that the patient has good strength. Or can they bend their knees up off the bed? Do we have 4 twitches? So is our train of 4 good? This all gets into that sedation vacation kind of thing that we get into. Is the oxygen level on the ventilator at least down to about 40%? And is their PEEP down to about 5? Because now we're getting into normal physiological PEEP. So these are some areas that you start looking at first, and can you check these boxes off? And if you can't, then what's going on with these patients? Always remember, what was the initial indication? So has that been resolved, or is the patient improved? What is their sedation level? Someone who's at -4 is not going to be weaned, but also a patient who's at +4 on a RASS score is not going to be weaned either. We've got to figure out what's going on. BIS monitoring, is the patient psychologically ready? Can they understand what you're ready to do? Are they able to participate in that weaning and that extubation? We do wake-up assessments. The therapists look at spontaneous breathing trials where the ventilator is set at the most minimum settings, and we see what the patient does. Do they stop breathing? Do they become kidney? Do they get diaphoretic? Do they get tachycardic? All those things like that. Respiratory therapy looks at numbers like this. Is the respiratory rate less than 25 spontaneously? Do they have a good negative inspiratory force? Can they pull in? Can they really suck in really good to give themselves a good volume? Is their own breathing volumes at least 5 mils per kilogram? What is the settings again? What is their PaO2? That should just be greater than 60 millimeters of mercury on an FiO2 of 40% or less. A little typo there. Minute ventilation is calculated by respiratory rate and times the tidal volume. And are they within the normal? The normal range is 5 to 6 liters per minute. Also, we need to check to make sure the patient doesn't continue having the problem. Abdominal distension is a big thing. Why we talked about that, especially with morbidly obese, that's going to interfere with ventilation. So is pain under control? So these are the other little secondary and tertiary little checklists that you want to use. Reasons to stop weaning your patient. We're going to say, no, Fred's not tolerating this because now he's very tachypnic or he's very bradypnic. He's very agitated. He's all diaphoretic. He's in there and he looks like a fish out of water. He's having to use accessory. His heart rate's gone up by 20%. He's now having ectomy. He has ST segment elevation. My Lord, no, we need to stop because we're almost knocking Fred out here. Or he becomes unresponsive or he becomes very combative or agitated. Then we would need to stop that weaning. Are we ready to extubate? So the patient was weaned. Now can we remove the endotracheal tube? Can the patient protect their airway? Have they been intubated so long that I may have airway edema? If I have a potential where the patient's possibly going to close off their airway, I'd rather leave the tube in because I don't want somebody to have to have an emergency trach. Can they control their secretions? Can they cough? Do you feel like if you get the ET tube and you move it, does the patient cough? If you move the ET tube in or out or from side to side and the patient doesn't cough, where's the gag reflex? That patient is not ready to be extubated. What is their sedation level? Are they at a -4? No. Are they at 0 to -1? Okay. How well did they oxygenate? And how well can they ventilate? When we look at how well they can take good deep breaths in when we talked about the negative inspiratory force. And what's the pulse ox and the end tidal look at? Are we pretty much in acceptable ranges for our physician, what their goals are, what they want for our patients to be in? Let's talk about ARDS a little bit. There are 3 critical care criteria that we say that a patient is in ARDS. One, they have refractory hypoxemia. We talked about what this was. We keep adding O2 and the patient just cannot be oxygenated. You pull up the chest x-ray, they have bilateral infiltrates. It almost looks like a snowstorm. If you read the radiologist report, you may see the term ground glass appearance. this is a big indication that your patient's in ARDS. Respiratory therapy does this, but you're also able to do this. It's the PF ratio. Is it less than 200? What you do is you take the P, it's the PaO2, you divide the FiO2 in percentage form into that oxygenation level. If that number, which does not have a unit of measurement, is less than 200, and it's an indication of severe hypoxemia or the indication of oxygen usage, then we say that the patient has a PF ratio of less than 200, then they most likely are in ARDS. If they are already intubated, that number has to be less than 100. ARDS, the biggest problem is that, so you have three types of pneumocytes or alveolar cells. You have the type 1 that actually the gas exchange occurs in. Your type 2 alveolar cell is where surfactant is being produced. And surfactant is this fluid that lines the alveoli to help it expand and contract. Well, surfactant, it basically kills off the type 2 alveolar cell. So instead of having this beautiful alveoli, they can expand and contract, where as volume gets in there and get up against the capillary bed, the alveolar capillary distance in there is right together. I have this poor, damaged, dead alveolar cell, or this pneumocyte, simply because the type 2 alveolar cell has been killed. And here again is that same picture. And so you can see what's going on. To the left, you see that type 2 alveolar cell at the 9 o'clock area. The type 1 cells are up there. Everything looks really nice. I've got good blood flow. But then you go to the right, your patient, now look here. Now we've got all this cytokine action that's going on. The type 2 alveolar cell is there, but it's not functioning. The interleukins, those cytokines, especially 1, 6, and 8, start getting in there. Interleukin 1, it deals with inflammatory, so we start getting all that in there. Interleukin 6 deals, it's an inflammatory, but it's also an anti-inflammatory that's going on. And then interleukin 8 gets in there, and pretty much interleukin 8 is getting in there because of all the neutrophils. And neutrophils is an indication of inflammation when you look at that. Because you look at basophils, eosinophils, and neutrophils. Neutrophils deals with the inflammation. Well, interleukin 8 gets in there, which is your leukocytes. Your tons of leukocytes, your white blood cells getting there and trying to take care of all of this. So now we got all that activity going on, all those macrophages and so forth going on. And now we got all this fluid leak between the alveoli and the capillary bed. So this does not facilitate oxygenation and ventilation. I can't get O2 in and I can't get CO2 out. So we can understand now why these patients are refractory hypoxemia, why they have respiratory failure type 1. And eventually, after they have sat there for so long not oxygenating, and become very tachypnic and very dyspneic, they now are going to start developing respiratory failure type 2. So therefore they can't ventilate, so now they're going to become sleepier. And so now they're in acute respiratory failure, basically type 1, type 2, or type 2 gives you both pretty much. And they become very hypoxemic and they go into respiratory acidosis. And we can see the problem with that. And here is a chest x-ray that indicates this is a patient that has ARDS. And you can see all the issue, and we can see that this is not what's supposed to be. And the lungs are just full of fluid. This is a nice little slide that talks about direct and indirect causes of ARDS. So the effects are increase in capillary permeability, so a lot of leakage of fluid, damage to the capillary endothelium occurs, so that's where a lot of that leakage comes from. The alveoli and the endothelium, the pneumocytes secondary to the type 2 alveolar cells become damaged. Basically, the alveolar cell just dies is what is happening. So you get that shunting and so forth that's going on, and that shunting that is occurring is that the oxygen, the blood is looking for oxygen, and when it can't find it, let's say here, it's going somewhere else, going, well, I'm going to go over here and see if I can find my oxygen, because the body is demanding the O2. The body wants oxygen. Here is one of the management things for ARDS that we could see. We do low tidal volumes to help decrease the barotrauma or the volume trauma, and we sometimes give them high respiratory rates. We try to use a lot of PEEP, and you can see there, SATs of 88 to 95%. Normally, our goal is to get patients to 94 to 99% with a lot of other issues. But here we keep the oxygen level low. And we're trying to correct their acidosis and plus keep them dry. Look at all the fluid where it is. So let's dry some things up a little bit. And also too, because of the high levels of PEEP, we can also help keep those kidneys working too. So our patient doesn't go into pre-renal acute kidney injury. So as far as when a patient would be dealing with mechanical ventilation, when you are caring for them, you're thinking about, I need my ventilator settings to optimize oxygenation and ventilation. I'm going to be working to maintain those hemodynamics to keep them in the acceptable range for the condition that is going on with the patient. You're going to be sedating that patient or providing analgesia and some type of sedation. You may have to put them on a drip. You may be using propofol. You may use Precedex. We may be having to paralyze. Know your ventilator settings. Ask your respiratory therapist to help you. Go, hey, what do you have them on as far as FO2? What mode is it? Explain the mode to me. That's what they're there for. That is your partner, especially right now in these times. That's who you need to be buddy-buddy with. Prevent your VAP. Don't forget, if they can tolerate the head of the bed up, if hemodynamics allows it, then don't forget about doing your VAP. Work as a team. Have communication. If you see there, I also have dietitian. We have dietitians surrounding that want to know certain things about the patient because we want to make sure the patient is getting good carbohydrates, a lot of calories, so that they have the strength to wean and get extubated off the ventilator, but in turn to also have the strength to get well. Weaning and extubation is teamwork. Again, have those conversations. Does everybody agree Fred can now be weaned? We do it normally in the morning. This is when you have the most staff there. You do not wean and extubate at 2 o'clock in the morning because one of the rules about weaning and extubate, especially extubating, are you prepared to re-intubate if something happens to that patient? Do not forget to know what your policies or your procedures or protocols are for your department. What, as you as a nurse, what things can you do to the ventilator? Now, yes, some of these things are all being adjusted due to this pandemic we've got going on, but don't forget to make sure you stay within your scope of practice. What are your standards of care? What does AACN tell you? What is the procedure manual? And who is your support staff? If you have a patient on a ventilator, is it your coworker next door? Is it your therapist that's there? Is it your nurse educator? Who is your support staff to help you care for your patient on mechanical ventilation? Steve and our CEO asked me to throw this up here. If you have questions, please write them in, send them in. They will get forwarded to me. If you have any questions at all, also, you can just contact MedEd for anything that you need. If you need to get your copies of this, he's pretty much going to send them out. But questions related to this lecture, you're welcome to send in questions. We'll look and see if we have some up there. Usually what I do is at the end to see if we have some Q&A, and I usually read them and go over them. I put this up here because right now we're definitely caring for each other. I want to thank you as one critical care nurse to another critical care nurse, no matter where you are from. Take care of yourself. I make sure that when I'm off, I do nothing. I try to not read the news. I try to do something either with my family. I enjoy my chihuahuas. I enjoy a little bit of scotch. I like to watch Netflix, but take care of each other. One good thing about everything that's going on right now, it has made me really appreciate my coworkers. I am so honored that I can go to another department and work with a great group of nurses. They are so dedicated. A lot of them are working a lot of overtime instead of being at home with their families. So I congratulate you. Know that as nurses, we are a strong force together. What I want to do is I'm going to go up here and hit this Q&A, and I want to see if there's questions. I see a lot of thank you, thank you, thank you. Do you have anything? What I can tell you, Frances said thank you again as an ED nurse. This was helpful to her as well. For those cross-training, This, yeah, very helpful cross-training to ICU from PACU. It looks like Shauna is saying the same, getting a crash course training. This was something that she appreciated. Michelle says this was a wonderful presentation. She thought it helped her too. It is changes. We're being put in situations and we're having to do things we normally don't do. As one nurse said, if I do the things I'm doing now, if I did them a month ago, I probably would have been fired. Yeah, I'm having to, do a little bit more. I was so nervous the other day. I had drawn an arterial blood gas so long, and I had to do that with my COVID patient. And I was nervous. Yeah, I made it through, but I had to go back and think about doing that. This is stressing us. We're having to learn all together. It is harder to take care of these patients than normally just walking in and out. But I just, any cheat sheets available. Yeah, cheat sheets as far as things you can do. One, I would definitely just go to Google. I found a way to go to the internet on my phone, find pictures and put them in a file. The respiratory failure type 1, type 2 is one that I have downloaded. I was able to also download a protocol for ARDS protocols that I sometimes use. I even found a cheat sheet on the neuromuscular blocking agents for intubation, the drugs and so forth, just to refer back to, and those for maintenance. And let's see, Emily Hyman said, can you touch on the information coming about COVID-19 being true ARDS? How is COVID differently from? Well, I will tell you what I've known. I've been trying to do a lot of reading because I just turn into a nerd sometimes, and then I develop some insomnia, and then I just want to stay up all night. So several things about this, Emily. One, there is a lot of questions. Are the patients basically ARDS type patients? When you look at the presentation, the critical care criteria for ARDS, they're meeting that, but they're also having questions when they do CT. Is that really ARDS? Do we treat them like that? Personally, we have tried, or not personally, but as a team, they've tried some proning, but the proning did not seem, we've had several patients that did not tolerate that hemodynamically, and it did not seem to be any benefit. So right now, from the charge nurse that I talked to the other day, she told me proning has been put on hold. I know that some hospitals are looking at ECMO, extracorporeal membrane oxygenation, to help with ARDS patients that are these COVID patients that are acting like this, to help them oxygenate. We are keeping oxygen saturations to about 88 to I think 90, 92%. So we're sort of looking at them like at ARDS, but we're still also doing a lot of antibiotics as if it's like a, to me, almost seems like there's like a pneumonia type patient that has developed ARDS. I sort of get, that's what I'm starting to see there a little bit. So it's very, I think day to day, you're going to see changes. So yes, I think they act like ARDS. Is it true ARDS? I'm not sure if it is, but we know that patients get respiratory infections and they can go into ARDS. They get viral and bacterial. Well, this is a viral, this is airborne, this is contact. So yeah, it can. I mean, this is for the infectious disease guys. This is the pulmonologist to come out and tell me that. Just tell me what's going on and what our goals are so I can take care of my patient. Sharon Roseman said she is an FNP student and we are allowed to watch webinars to make up clinical hours this way. Great, I'm glad we could do that for you. She said she was a PACU nurse for 19 years in a large hospital in DC and they managed their own vents. Great, yeah, respiratory therapy would come into our PACU. They set it up and they'd move on and we would manage ours also. So I'm gonna see if there's a few more. When the patient is proned, there's a question about should ventilator change. I think what I'm saying is the therapist a lot of times are doing could do lower volumes and higher rates to try to keep some type of normal minute ventilation, but you think basically about proning. really is changing the mechanics of the thoracic and the abdominal cavity. It's basically getting the stomach off of the lungs so that we could truly ventilate the base of the lungs. And how we, how we do that is to prone a patient. And so therefore we can get that down at the lower part of the chest wall where we're auscultating posteriorly, those breaths, to let them get oxygenated more. Let's see, I was under, Carlo says, I was under the impression that COVID was only airborne until using an aerosol med. I'm graduating in May. Okay, so this is something, and Carlo, thank you for reminding me this. There have been questions too about why could we not use BiPAP on these patients? Well, first of all, you're correct. It is not just only airborne. It is a respiratory virus, but it's also contact. So this is one reason too, because of the airborne, everything, the patient we need to intubate them mechanically, because then we can control or contain the virus. When patients on BiPAP, it gets aerosolized out into the air. So therefore that whole room, everything, anybody that comes in contact gets major exposure to the virus. So BiPAP is not indicated. Friday, we had a young lady that told me that what they're doing with patients that were DNR or no code blue, they were putting them on BiPAP. But when I explained to them, I said, you guys need to really make sure that you are gowned up, because that patient is really just putting that virus out there. But BiPAP is not something that is recommended. Our hospital system is total no on that. Velda Handler wrote in, is sharing a ventilator with 2 patients really something can even be done? I am not impressed with that. I have not seen the evidence, the research to support it. There are videos out there. My current and past respiratory therapy friends are like, no way, Jose, on that kind of thing. They feel like, because of the different compliances that occur, it's 2 different patients. So they just don't feel like it's something that you could be doing with that. Heather Anderson's from Canada. Welcome, Heather, to the U.S. and listening to me down here in North Carolina, where we like our tenderloin biscuits and our iced tea. Do you have a course on clinical presentation treatments of COVID patients in an ED setting to admitting? Sharon, right now it is not. I encourage you to, if there's an evaluation following this course, I encourage you to send that information to our wonderful staff at MedEd, and let them know some needs or things that you want. We'll be glad to either get you with that information or find you some way. If not, I will try to find you something, but we'll try very hard to get you some good solid answers based off of evidence-based practice and research, and that I have good references. But you have to understand, with what is just happening, there's not a lot out there. We're all still fishing around trying to figure out what the heck is going on. Is BIS of 70, 80 is a pretty standard. In our practice, in our critical care unit, that is where we're sort of keeping the patients right there at that sedation. Again, it's based on the RAS score that we look at. It's also the orders for sedation management of our patients that are intubated, mechanically ventilated. The physicians mark where they want us to keep those patients. Just know that once you get down below 50, that is considered general anesthesia. And I don't have CRNA after my name, so I'm not going there. I'm trying to think. I believe Catherine's helped me go through all of this stuff, and it looks like we have, Brooke Snow just said, thanks so much for this. Crazy times. I'm an ER nurse. Girl, you are on the front line. Please protect yourself. I don't care who's coughing what. I'm wearing a mask. I'm wearing a face shield. It's great to boost my confidence. You've got this. You are not alone. Let's remember, we are all not alone. Is with the experience that I've had. I've been in our system now. This coming year will be 33 years working as a nurse and respiratory therapist at different times. I still have questions. This is how we learn. It's called the nursing practice because we constantly practice our art and we're constantly learning. And by doing this, you are showing how you are supporting yourself, your profession, your coworkers. Hopefully you can take this back and share some information with your coworkers. I'm going to close this out. God bless everybody. Take care of yourselves. Just remember, as nurses, we're a great team and we will beat this together. And I want to thank everybody.
Thank you, Michael. You did a great job as always. Thank you for everybody. On the East Coast, it's, you know, pretty late, but appreciate everybody taking some time out to watch this video. And again, as I said at the beginning, we will be emailing everybody the PowerPoint slides along with the recording. So again, if you have any questions for Michael, you can email those to questions@mededseminars.net. And if you have any just support questions or any other suggestions of topics, you can email customercare@mededseminars.net. I really appreciate your time and stay strong, and we'll be here to support you in any way. Just let us know what we can do to help. Have a good night.
Good night, everybody. Thank you, MedEd, for sponsoring this.